So, good afternoon, ladies and gentlemen. I'm pleased to have this opportunity to present the guidelines to improve the continence care of people with dementia living at home. And this is the report which hopefully you have by now found in your conference bags, and it will soon be available on Alzheimer Europe's website. So in the next 15 minutes, I hope to give you a brief background about these guidelines, explain why it was important to develop them, and then give a brief overview of some of the key points from each section. So I'll start with an explanation about how the guidelines came about. So there were initial discussions between Nicole Hauger from SCA and Jean-Georges from Alzheimer Europe about the importance of this topic for both organisations, and this led to a collaboration between the two organisations and the start of a 2-year project to develop guidelines on the continence care of people with dementia, specifically living at home. In view of the lack of solid evidence from the literature, a structured, consensus-based expert consultation approach was adopted. First, we set up a steering committee, then a working group of relevant experts. Following a literature review and a meeting to discuss the findings and identify the key areas to discuss, a first draft was produced and discussed at subsequent meetings. A draft version of the guidelines was presented at the Global Forum on Incontinence, which was held in Madrid earlier this year, and this was followed by a consultation phase involving experts, people with dementia who are also experts, and carers. The members of the steering committee and the working group all had knowledge and experience in continence care and/or dementia, and in most cases in both. They came from a range of backgrounds, including nursing science, continence nursing, general practice, continence product development, social welfare policy, and psychology. And in addition, there was one person with dementia from the European Working Group and one informal carer with experience of continence care at home. There are 3 main sections. First, there's background information about dementia and continence problems, followed by statements from people with dementia and carers, and the guidelines on the detection, assessment, and management of continence care. So, why do we need the guidelines? Well, most people with dementia live at home, but incontinence and cognitive impairment in people with dementia may be a predictor for entry into residential care. So it's therefore important to ensure that people with dementia and informal carers receive appropriate and timely support to enable them to remain living in the community and playing an active role in society for as long as possible. Unfortunately, very little is known about the needs and care of people with dementia living at home who have incontinence. Guidelines for the care of people with dementia and incontinence or continence problems in residential care settings cannot simply be taken and transposed onto the situation of people living at home in different European countries where untrained non-professional carers, family and close friends often, and people with dementia themselves often have to cope with limited or no support. The guidelines are targeted at informal carers, health and social care providers, policymakers, and to some extent people with mild dementia. The format of the report is obviously quite dense, and we're in the process of extracting the main issues to provide a short, more dementia-friendly version, which will soon be available on our website. So our aim is not to replace general guidelines and recommendations on dementia care or continence care, but rather to ensure that existing guidelines and procedures are suited to the rights of people with dementia living at home, and to highlight areas where additional attention may be needed. So in the report, we include a set of statements reflecting the needs and wishes of people with dementia and carers based on the literature and consultation with members of the European Working Group of People with Dementia and also carers. These needs and wishes are not always met, which further emphasises the need for these guidelines. So I've just selected 3 examples, which are as follows. So we would appreciate a sensitive but pragmatic approach to continence issues and dementia, which recognises each as a medical condition amongst others, albeit with physical, social, economic and emotional consequences. We would like to live independently and avoid being unnecessarily dependent on others, and for this to be possible, we need appropriate care, support and treatment for dementia, and if and when necessary for continence problems, from healthcare professionals with a knowledge of both conditions. Similarly, with regard to informal carers, they have specific needs linked to providing continence care or supporting a person with dementia who has continence problems living at home. And again, I just quote a few examples of the statements we have in the guidelines. So the first, providing continence care to a person with dementia can affect us emotionally and psychologically, and we would appreciate greater sensitivity from healthcare professionals. We would appreciate recognition that we do not necessarily have nursing skills, that we have our own personal limits, and that we need varying levels and types of support to ensure continence care. In focusing on improving continence care for people with dementia at home, we must consider three key factors, namely continence, dementia, and age, and in particular, the point at which they intersect within the context of people's own homes and communities. Dementia is a condition which poses additional challenges for the management of continence problems, and the likelihood of developing dementia and/or of having difficulties with continence increases with age. Difficulties with communication, understanding, and memory, which are typical of dementia, as well as difficulties with mobility, which may be associated with both aging and dementia, may result in a person simply not reaching the toilet in time, and people with dementia may also have difficulty identifying the toilet and with the actual procedure. So there are several factors which are more common in older people and which may contribute towards incontinence. So these include comorbidities such as diabetes, congestive pulmonary disease, sleep apnea, stroke, Parkinson's disease, normal pressure hydrocephalus, and depression. Polypharmacy, in other words, taking several prescription drugs, becomes increasingly common as we age, and there are certain physical changes in the aging body. Drugs prescribed for Alzheimer's disease, for example, anticholinesterase inhibitors, can also cause or worsen incontinence, and some antimuscarinics prescribed for urinary incontinence have been shown to impact on cognitive impairment. So consequently, such drugs may be used, but with caution due to the effects of their interaction and the possible side effects. Nevertheless, despite the important relationship between aging, dementia, and continence problems, it's important to bear in mind that there are also younger people with dementia, but also that although age is the most significant risk factor for dementia, it is not an inevitable part of aging, and many people will live well into their 80s, 90s, even over 100, and not develop dementia. And similarly, despite certain physiological changes and medical problems or diseases which are more common in older people, incontinence should not be considered as an inevitable part of aging. On the other hand, the prevalence of incontinence amongst older people may seem to increase as the number of older people continues to grow at a proportionately faster rate than in the past. We identified a few overriding principles which apply to the subsequent sections on detection, assessment, and management of incontinence, namely, that continence care and treatment should be provided in accordance with the needs of carers and people with dementia and within a holistic perspective. That treatment and care options should be considered for people with dementia in accordance with national, European and/or international clinical guidelines on all related issues. The guidelines reflect the ethical framework which guides this study. So whilst we recognise the importance of the biomedical ethical principles, the guidelines heavily reflect a care ethics perspective which emphasises the lived experience of and dialogue between all involved, an interpretation of different viewpoints, and a need to consider potential vulnerability and dignity within the care process and not to focus solely on autonomy. There are a few important potential barriers to detection, such as the normalization of incontinence and dementia. In other words, the belief that it's normal or to be expected as a person is older or has dementia. Also, communication difficulties, lack of awareness, stigma, and shame. Our main message in this section is therefore to look for signs of incontinence, to ask about it, and to be proactive. More concretely, to approach the topic of incontinence with great sensitivity and with consideration for the feelings and psychological well-being of the person with dementia and their entourage. Not to avoid the topic solely on the grounds that it's a sensitive topic or a social stigma, and for GPs to ask about continence when a person is diagnosed with dementia and from time to time thereafter. We present a series of points upon which to reflect in order to challenge the stigma of both conditions, which you will find in the report. An interdisciplinary approach is essential. Awareness raising should therefore also be targeted at health and social care professionals, as many lack the necessary knowledge and expertise. The need for training to both healthcare professionals and informal carers on both themes, dementia and continence problems, is highlighted. With regard to assessment, I quote from the guidelines: "A proper assessment, diagnosis and initial treatment for incontinence should be offered irrespective of whether a person has dementia, is advanced in age, lives alone, or any other discriminatory criteria. It's important to start from the assumption that people with dementia should be eligible for any tests that would routinely be carried out, as well as for referrals, and that they should have the same right to consult a specialist for continence problems as any other person. Measures should be taken to facilitate communication and support decision-making of people with dementia, and again in the guidelines we include advice on how to improve communication and to support decision-making with reference to publications. However, training should be sought if needed. In the early and mild stages of dementia, incontinence is often strongly related to problems with mobility, finding the toilet and toileting skills, and these factors sometimes can be influenced successfully. Once a type of incontinence has been established, an individualized action plan should therefore be envisaged in a stepwise process which involves a progression from minimally invasive approaches, sometimes called conservative measures, to other approaches which are potentially more invasive. However, this should be considered as a guiding principle rather than as a strict rule to be followed. The actual choice of measure should be based on the individual needs, situation, condition, and wishes of the person with dementia, and be part of an interdisciplinary decision-making process. Measures should be considered which enable people with dementia to deal with incontinence independently for as long as possible. A coordinated care plan should be developed, involving the person with dementia and all health and social care professionals, as well as informal carers, providing dementia and continence care to a particular person. Support for carers must be a crucial part of any strategy, and incontinence nurses, advisors should also be involved. Due to the complex and changing needs associated with both dementia and incontinence, it's essential to have one person with overall responsibility for the organisation and coordination of the continence care of each person with dementia living at home, for example, a case coordinator or a case manager. With regard to medical treatment, nursing care and surgery, an overriding principle should be to assess potential risk against potential benefit and quality of life of the person with dementia, and above all, avoiding the stereotype that people with dementia have no quality of life. Moreover, people with dementia should be given the opportunity to benefit from treatment, care and surgery on an individual basis, and have a right to accept certain risks if they have the necessary capacity. To conclude, dementia and incontinence are complex issues triggering long-term care needs that have to be addressed by health and social care professionals in cooperation with informal carers and people with dementia. Continence care must be approached from a holistic perspective. It must aim to improve the quality of life of people with dementia. It must empower people with dementia and respect their dignity, integrity, well-being, and autonomy. And it must provide informal carers with the support they need and to respect their rights and needs. Thank you for your attention.
Thank you, Dianne, for a wonderful presentation and a really important subject. I'll take one or two questions. Again, Dianne stuck to her time, so if you've got a question, please just put your hand up. Okay, Archie, yeah, just at the front here. Thanks, Archie. There you go. They've just got behind you. Yeah. Thank you.
I noticed during your talk that you didn't mention gender at all, male and female. I wear a pad all the time myself, but I found it extremely difficult when it first started with me to get the proper pad to do the job. To make you laugh a little bit, I was running about like Henry VIII with a codpiece on. And I've cracked that joke quite a few times, but it actually runs true. We have not. The male toilets are not equipped with the bins that we can put our pads in. So consequently, I run about with a thing called a little doggy bag. I put them in, and I dump them every time I actually need to dump them. And I find the most embarrassing thing is when I do leak. It's the case that I can't get a proper pad to actually fit properly to make me feel like a bloke and not like anything else. And what can the professionals do to help in this way? On the 27th of this month, we're going to make a film about this particular problem. And it's something that we must do, we must get men in particular to go to their GPs to actually tell them what the problems are. Because there's many things, they've got many drugs in the GP's arsenal that can actually solve the problem or make it less embarrassing. And that's all I'm going to say.
Thanks for that, Archie. Dan?
Thank you for sharing your experience. I think that it's a very important issue that you raise, and it's very courageous in a way to speak out about the problem. And I think that we do need more people to actually bring up the issue with the GPs, because sometimes they are quite hesitant to broach the topic. But also the issue of actually finding appropriate products. I think that's where the importance of continence nurses and continence advisors is crucially important, and not to have a kind of, maybe not the right way of putting it, but a one-size-fits-all solution, that there are lots of different products and different qualities of products. And I think that people with dementia and continence problems, they really need to have access to what's appropriate to them for their physical condition, their lifestyle, gender, and everything. And that is something that we address in the recommendations. And thank you very much for raising the issue.
Thank you, Dan and Archie. Thank you. Let's applaud Archie again for that.